thank you so much for your elegant talk. Our next speaker is Dr. Walid Rasheed. He is a consultant hematology and head of section of lymphoma and myeloma at King Faisal Specialist Hospital, RC, Riyadh. He's gonna talk to us about the role of autologous stem cell transplant in upfront setting in mantle cell lymphoma.
Assalamu alaikum. Good morning, everyone. Many thanks for the invitation to be with this meeting today. I was asked to answer one question, and that is or discuss one question, and that is is there a role for auto-transplant in the upfront management of mantle cell lymphoma in the current era? So I thought I would start with a case presentation. This is a patient who was seen in our clinic around January this year. A young man, which is a little unusual for mantle cell, as you would know, but he was 38, had unremarkable past medical history other than some eczema and urticaria problems, presented with 5 months history of neck swelling that has particularly increased in size over the last 2 months, with some fevers, but his weight was fine. A CT scan shows lymph nodes above and below the diaphragm. The largest is in the mesenteric area, about 6.8 by 5 centimeter. The spleen was mildly enlarged. He underwent a surgical neck lymph node biopsy, which showed classical mantle cell lymphoma. Ki67 stain was reported as exactly 30%, and P53 by immunohistochemistry was 10%. ECOG1, his LDH was only slightly raised. This was his baseline PET scan. As you can see, there's some lymph nodes above and below. There's particularly a number of lymph nodes amalgamated in the abdomen, as well as some inguinal lymph nodes, and his spleen was also mildly avid with no focal lesion. So the question really is, this was a presentation about 10, 11 months ago. The question is, would you, when you counsel this patient up front, would you recommend auto-transplant as part of the frontline therapy in his management? And I would like just to ask, if I may, with a hand show, who would, in the audience, support recommending auto-transplant for this patient as part of his management of his lymphoma? Can I? Okay, very few hands, maybe 3 or 4. Who wouldn't recommend auto-transplant? Okay, maybe 7 or maybe 10. So the largest group is in the middle somewhere, not voting. Okay, so we'll see what happened to this patient at the end. So a brief background, you know, mantle is a rare lymphoma, more in males, more in the older age group, usually advanced stage, and extranodal disease basically in the liver, the spleen, sometimes in the gut is frequent, and these are some percentages about involvement extranodally. You would be familiar with the term leukemic or indolent non-nodal mantle cell lymphoma, the classical mantle cell lymphoma, and as patients progress down the line, they can acquire more mutations, including P53 mutation, and they can become more aggressive, including the blastoid mantle cell lymphoma variant. Most mantle cells are nodal. They are more aggressive than the leukemic mantle cells, obviously. SOX11 is overexpressed. And the non-nodal, they are usually SOX11 negative, and they have a low proliferation index, and they tend to have circulating lymphoma cells in the blood. You're familiar with the MIPI score, obviously. People either use the calculation one or a simplified MIPI, basically based on the age, performance, LDH, and the white cell count. And incorporating Ki67 score into the MIPI has yielded a much more potent prognostic factors into, so you can see the curves when you incorporate Ki67, the curves really separate quite widely in addition to the MIPI score. And these are the two studies down in the slide that highlight how important the proliferative index of the mantle cell lymphoma on biopsy. And the calculation is very simple. You will have to have your MIPI, and then whether it's low or intermediate or high or intermediate high and so forth. And then you combine it with the Ki67 score, whether it's below or above 30, and you end up with the biologic or so-called combined MIPI score that will be much more prognostic. Other prognostic factors, as you can see here, include TP53. Ideally, it should be by molecular NGS sequencing, but I don't think this is widely available. I can tell you in our lab, I tried several times. I couldn't get a mutation analysis on the biopsy or on the bone marrow. It's not validated in our lab. And we ended up just with the immunostain in this patient. Obviously, the low-risk patients can be observed, and these are studies from more than 2 decades ago showing that observing patients who have the very low indolent mantle cell lymphoma is quite fine. They don't need to be treated. And as we move in the last 2 decades, we can see several studies that have gradually changed the paradigm of management in mantle cell lymphoma. This is where rituximab has become very important in mantle cell lymphoma specifically. And then the FCR that used to be a treatment option is obsolete now. This is a study that showed that R-CHOP is better than FCR. Overall survival, and FCR is not used anymore. And then we come to the European Mantle Cell Lymphoma Network randomized phase 3 study that showed that auto-transplant has become a treatment option that is recommended in mantle cell lymphoma in younger fit patients. You can see various groups. I won't get the details, but the various groups here. The blue line is the transplant. Some patients had rituximab, others didn't, in this rather old study now. But the one important slide here is the randomization of transplant versus interferon, and showed clearly that PFS is more than doubled in this study, although overall survival was not significant. On a follow-up study, a follow-up publication of the same study a few years ago showed that with longer follow-up, there is a survival advantage, but mainly in the ones who are rituximab naive, but not the ones who received rituximab. And then comes the RSC treatment in mantle cell lymphoma, and this is the mantle cell lymphoma younger trial that showed that incorporating high-dose RSC with the DHAB has yielded a better outcome. Obviously, both arms were transplanted, and when you have RSC on board, you have a better treatment time to treatment failure curve. Even MRD negative achievement is better with the RSC arm. And you can see PFS is more than doubled with the cytarabine group on this slide. However, overall survival was not significant on this study. On a long-term follow-up, maybe more than 10 years, on a subsequent publication last year, it did show a survival advantage, as you can see here, but only when it is adjusted for the MIPI score. Then we can see a survival advantage with the cytarabine arm. Obviously, both arms were transplanted. This is the French study, again in younger patients, all received RSC-based therapy, and then monitored either observation or rituximab maintenance, or all transplanted, and it did show a better outcome with rituximab maintenance. So rituximab maintenance is widely recommended in mantle cell lymphoma, whether it's young, fit patients or whether it's in older patients. This is basically highlighting the role of rituximab even in the non-transplant patients. It's important to note that we're discussing a standard risk mantle cell lymphoma, not the high risk p53 mutated patients, but on this particular group, I'm not going to mention here, but in this particular group, for example, in this sub-analysis of the RSC study, it showed no benefit of high-dose RSC regimens in the p53 mutated patients. Now, one slide on the MD Anderson hyper-CVAD in mantle cell lymphoma without a transplant. They showed a good outcome. This is a 3-year overall survival of 82%. However, this regimen, I think, is not widely used nowadays because it's quite toxic. And if you think to transplant patients, you will have difficulty collecting stem cells. So it's not really widely practiced, I think. One other option among the RSC, high-dose RSC mantle cell lymphoma is the incorporation of bendamustine, rituximab versus plus rituximab high-dose RSC. And this is a study that incorporated a couple of phase 2 studies, smaller number, plus another cohort, retrospective, and showed quite impressive results with 97% response rate, CR rate 90% at the end of induction. These patients were transplanted, and the 3-year PFS, 83% overall survival, very impressive numbers, but the follow-up is only 33 months. There were no treatment-related deaths, but very common cytopenias and sometimes febrile neutropenia. So if you like guidelines and recommendations, this is from the education book last year, from the ICML book, and you can see here on this, on the fit patients, on the left side, a transplant says high-dose consolidation followed by transplant plus minus. So it's, as of last year, was still an option, plus obviously rituximab maintenance. And then comes this trial, which made significant changes in our thinking of treatment of mantle cell lymphoma, the Triangle trial, a very large study of more than 800 patients across mainly Europe, and these are patients who are younger than 65, and to 3 groups. Basically, group A is R-CHOP, R-DHAP, or oxaliplatin instead of cisplatin, followed by a transplant. Group A and I is with the addition of ibrutinib in the R-CHOP part of the chemotherapy, as well as for 2 years fixed duration after transplant as a maintenance. And group I is the same, but without a transplant. And in terms of rituximab, it was left for the national local guidelines of each country to use rituximab. But you can see here about 50% of patients did have rituximab maintenance in all of the 3 arms. And to cut it short, these are the results of the study. It basically showed that comparing group A and I to group A, that the addition of ibrutinib to a transplant, there was a superior failure-free survival of 88% versus 72%. But if you compare the transplant group versus the ibrutinib group without a transplant, there was no benefit. The comparison of a transplant plus ibrutinib versus ibrutinib is still ongoing, and it was not reported in the study. Of note, the ones who had a transplant as well as ibrutinib, they had more adverse events on this study. This is the failure-free survival curve, clearly showing that in the green one is the transplant plus ibrutinib compared with the transplant, the red curve. You can see there is a difference. This is failure-free survival. And you can see the difference is maintained when you analyze based on the Ki-67, less than 30 versus more than 30%. But the curves really separate widely if you start to look at P53 immunohistochemistry stains, and those who have more than 50% positivity on the biopsy, curves are really widely separated, which tells you that ibrutinib is probably the one who's making difference in these patients. It's quite remarkable in that setting. And as I said, comparing a transplant versus the ibrutinib group did not show superiority of the transplant. The overall survival of the three arms was very similar. These are the author's conclusion that there was superior efficacy by the addition of ibrutinib to a pre-trial standard treatment in young transplant-eligible patients in mantle cell lymphoma. And when you use ibrutinib, transplant does not result in a superior efficacy compared with high-dose cytarabine-containing chemotherapy combined with ibrutinib maintenance. So whether a transplant adds efficacy to ibrutinib-containing regimen, outweighing the toxicity that I mentioned with the combination of transplant and ibrutinib, is not yet clear. Now, one question that is not answered in this study is how does this compare? Say, I don't want to give this patient ibrutinib. I'm going to do a transplant as we have been doing for many years, and I wait until he or she relapses, and I'm going to use ibrutinib then. Does that make a difference? Do I get the same outcome? Obviously, this question is not answered in this study. We don't have randomized studies answering this question as of yet. And you know, there's so many targeted therapies now, mainly in the relapse setting in mantle cell lymphoma. This is a brief table from the education book of the ICML publication. Lots of ibrutinib, acalabrutinib, zanubrutinib, as well as lenalidomide, and many other options are used mainly in the relapse setting. And these drugs have been now moved to the frontline setting in a number of trials that are still ongoing. And many of them are approved in the relapse setting, as you can see here. We also have CAR T-cell therapy approved in relapse setting. So the idea is there's so many treatment options in mantle cell lymphoma now. So the question comes for future, do I need to do a transplant in mantle cell lymphoma in younger patients? I have novel agents, I have CAR T-cells, and so forth. Can I omit transplant in these patients? Obviously, in this Braxicell study, there's quite a sustained curve at this stage and those who respond, as you can see here. I'll skip this slide. So a couple of slides for those who like guidelines. So in the British guidelines of last year, it does still recommend a transplant as a consolidation therapy in younger patients, but on the same time, offering ibrutinib as per the triangle study is also an option. So both options are valid. In the NCCN guidelines, again, you can see here, offering a triangle study protocol up with ibrutinib plus maintenance rituximab versus transplant. Both are options. Obviously, the P53 mutated have a different treatment recommendation. This is just the last slide before I tell you about the patient from a recent review article by Dr. Ann here, showing some of the studies that are in the pipeline in the frontline setting in mantle cell lymphoma that may help answer this question and other questions about mantle cell lymphoma in younger patients, including incorporating novel agents such as acalabrutinib, zanubrutinib in the upfront setting. And we have one study that compares transplant versus maintenance, rituximab only in the younger patients, and that is still ongoing. So our patient was discussed in an MDT meeting, and he was offered treatment with a high-dose RSC-based regimen. In this particular case, we used rituximab bendamustine for 3 cycles, followed by rituximab HiDAC for 3 cycles. This is his PET scan at the end of 6 cycles of chemotherapy. He was in complete metabolic remission, as you can see here. And he went to the transplant committee, the last slide coming, to discuss whether we should transplant him now. We collected cells, or whether we can give him rituximab plus ibrutinib maintenance. He never had ibrutinib in the first place with induction. And in the transplant committee, we ended up in a voting mode because there was no consensus. 50% approximately of the group voted yes, and 50 voted no. And I had to go and take this to the patient in the clinic, which is quite challenging. This is our group meeting, and how sometimes we end up voting if there's no consensus. So he was counseled of both options, including after the full publication of the Triangle study in May this year. He listened to the side effects of both options, including ibrutinib issues, and he elected to have a transplant. And he just had this transplant last week. So my conclusions is that the landscape of mantle cell lymphoma therapy have witnessed significant changes in recent times that I've shown you. The Triangle study in particular revealed promising results suggesting that the use of BTKIs may obviate the need of transplant in the transplant, so-called transplant eligible, which may not become a term to be used in the future. And we need longer follow-up, obviously, of this study, as well as other studies incorporating novel agents into the upfront setting. And that may, these results may likely change the whole paradigm in mantle cell lymphoma management in the future, I think. And thank you very much.